Well, welcome to ASJ Journal Club. So happy to have all of you with us tonight. It's really a milestone for us. We've had several lead next generation editors through the years and moderators of the Journal Club, but we now have said goodbye and thank you to Ryan Austin and Mark Albert, and welcome to Maryam Zamani and Deniz Sarhaddi as our new two co-moderators of ASJ Journal Club. So welcome, ladies, and I'm going to just do a quick intro. So happy to be here with our new crew. So Dr. Maryam Zamani is the lead next generation editor for ASJ and co-moderator of Journal Club now, and a body contouring contributing editor for ASJ Open Forum. Raised in Toronto, Canada, her training and career have spanned across the border. She completed her medical education and award-winning master's research in plastic surgery at WashU, followed by plastic surgery residency at University of Toronto, aesthetic fellowship training with Jim Grotting in Alabama. She's been in private practice since 2019, initially working alongside Julie Khanna in Toronto, and now building her own practice in Beverly Hills, California. She specializes in combining cutting-edge technologies and treatment modalities to enhance outcomes in aesthetic, face, breast, and body surgery, and is passionate about mentoring the next generation of aesthetic surgeons. Welcome, Dr. Zamani.
Thank you so much for that kind introduction, Phaedra.
Absolutely. And also with us is Dr. Deniz Sarhaddi, who is a plastic surgeon based in St. Louis at St. Louis Cosmetic Surgery. And after completing medical school at George Washington University in DC and plastic surgery training at St. Louis University, she completed her aesthetic fellowship at Emory Aesthetic Center and then joined her current practice. She's been working with ASJ and the ASJ Journal Club since 2020, and we're also delighted to have her here as a co-monitor. Welcome, Dr. Sarhaddi.
Thank you. Happy to be here.
Wonderful. With that, we'll hand over to Dr. Glener.
Thank you so much. So I'd like to do a brief introduction of all of our amazing panel, if that's okay, Dr. Glener, yourself included. And then I'll let you go ahead and take over the panel and then guide us through your amazing study, which has been so fantastic and we're so excited to discuss. So with that, I'd like to welcome everyone to our first ASJ Journal Club of the year with what I can only describe to be a star-studded panel of authors and discussants. We're looking forward to a very educational and lively discussion. So please make sure to use the chat box for any questions and comments, and my co-moderator, Dr. Sarhaddi, will then relay it to our panelists at the end of the discussion. For our discussion tonight, we've selected Outcomes in Office, High-Resolution Ultrasound Silicone Breast Implant Surveillance by Plastic Surgeons with lead authors Dr. Adam Glener and senior author Dr. Bill Adams joining us today. Just a brief bio of these amazing surgeons and panelists that are joining us today. So Dr. Adams is an international authority, innovator, and scientist on breast augmentation surgery, including new generation devices, support materials, capsular contracture, and ALCL. He's an associate professor of plastic surgery and aesthetic fellowship program director at UT Southwestern. And Dr. Adams has been the president of multiple societies, including our Aesthetic Society and ACER, and has received numerous awards as a top educator, panelist, and clinician. Presenting their study today, we're joined by Dr. Adam Glener, who's in private practice in Wilmington, North Carolina, and the brand new father. Congratulations. He's completed both his medical education and plastic surgery residency at Duke University, followed by aesthetic surgery fellowship at UT Southwestern. And for our panelists, we're so excited. Later on, they'll be joining us in our discussion. We have Drs. Pat McGuire and Dr. Pat Pazmino. Dr. McGuire is an adjunct associate professor at Washington University, president-elect of ACER, vice chair of the Breast Emergency Response Task Force, and a member of the ALCL subcommittee and co-principal investigator of the pivotal ACER-sponsored study on BII, just to name a few. And Dr. Pat Pazmino is an innovator in the field of incorporating AI with ultrasound to develop improved and safer surgical techniques, including his ultrasound-guided gluteal fat grafting. His work has been instrumental in improving safety guidelines and is recognized by the Tiffany Award, by the Aesthetic Society, and Patient Safety Award by the Foundation. So without further ado, sorry for the interruption. Dr. Glener, please take it away. We're excited.
Not an interruption at all. Thank you so much for that kind introduction. And I'm humbled and honored to have a few minutes to talk to you guys about something that Dr. Adams and I looked into last year while I was in Dallas with him. And it was really born out of necessity and solving a clinical issue for us where our patients weren't getting the access they needed for implant surveillance. And they weren't finding people who really owned that surveillance in terms of which people were responsible for doing that. So Dr. Adams and I sought out to prove that we can produce high resolution ultrasound images in the office by a plastic surgeon. And we sought to compare that to the gold standard, which is in the literature, MRI studies. So like I said, the primary objective of the study was to determine if plastic surgeons can use high resolution ultrasound for in-office silicone breast implant surveillance. And the secondary objective was to examine the long-term outcomes and implant survival rates using Dr. Adams' very long private practice experience. To do that, we designed a retrospective chart review, main inclusion criteria being that it was a silicone breast implant and it had to be placed by Dr. Adams to mitigate any confounding variables. And then we used a high resolution ultrasound data, again, performed in office personally by the senior author. I think it's important to look closely at what the images look like of an intact and a ruptured implant because it may seem a bit formidable to interpret these images live time with the patient in front of you, but when you look at it, it's quite straightforward. So I'll direct you to the bottom right there, which is a labeled portion of what's on the left and showing you what an intact implant looks like with ultrasound. So the breast parenchyma is up at the top of the screen, and then you see an orange line that's denoted, followed by a railroaded blue next to each other, followed by a red dashed line. So that orange line is the capsule of the breast implant. And then that blue line is the shell of the breast implant. And now on the top there is the same layout, but a ruptured implant. And I want to draw your attention to the top right. And you can still identify those blue railroads, which is your marker of the shell. So you know you're looking at the implant. But then you see that there's a lot of material between those two blue markers and the orange dotted line. That orange dotted line still representing the capsule, that's showing you intracapsular free silicone is what you see in that intervening portion. The yellow reflection often confuses folks. All that is the hydrated gel. When a silicone implant ruptures, that gel is hydrated, which changes its hypogenicity on an ultrasound, which is why you see that shadowing there. It's a reflection if you want to think of it as the gel being hydrated. So as you can see, pretty easy to tell if a patient has a ruptured implant or not, and something you can certainly do in live time. What Dr. Adams and I recommended for those not experienced with it was to try them on the patients in the operating room anyways, and then you can quickly see if you're accurate after you do the surgery. So our results showed that of the 508 implants included, 104 of them were operatively re-explored. Using those 104 implants as a complete test, positive or negative, the sensitivity, specificity, and negative and positive predictive values of ultrasound were calculated. And you can see here that the sensitivity is 90%, the specificity is 100, which is what we're looking for in a non-screening exam, but more of a concerned exam. And you can see there that the MRI data is on the right, and that's the average of all of the aggregate large studies published for the gold standard sensitivity and specificity. So you see in our study that we exceeded both of those parameters for MRI gold standard. The secondary part of our study, because we had such a long follow-up time, as you can see with this Kaplan-Meier curve, was to get a bit of an update in a private practice single surgeon setting of how these implants are behaving over time. So what we found was a 10-year survival rate of 98% and a 15-year survival rate of 80%. But we thought that 15-year survival rate was low, considering what we anecdotally found with our clinical patients. And what we found was that we essentially had a selection bias because a lot of these people were referred to Dr. Adams with concern of rupture. So what we did is we backtracked into a sub-analysis of the people who were only surveilled for surveillance purposes without any pre-test concern for a rupture or an issue. That limited us down to 402 implants. But what we saw was a much more appropriate 10 and 15-year survival rates, slightly better than what the data currently shows for the implants that were used in the study, which were all of the major manufacturers at the time. Conclusion to the study is that in-office ultrasound for breast implant surveillance is absolutely here to stay. And the argument of part of this paper, and if you read it, is borne out, is that we as plastic surgeons, in our opinion, should own this responsibility. We proved that it's as sensitive and specific, if not better, than the MRI gold standard, whereas the MRI gold standard has a $2,500 cost, takes about 3.5 hours. There's convenience barriers. Oftentimes radiologists are not comfortable reading those images. High-resolution ultrasound mitigates all of those barriers. And the last point I think here is even most important, considering the esteemed panel and discussants we have today, is that plastic surgeons are the most qualified people to deliver this implant ultrasound surveillance. Surgeons across the country, across different fields, use ultrasound in their daily practice. It's our argument that as plastic surgeons, we should be the ones doing this. We're the only people that have felt an implant, understand what a contracture is. The radiologists that are forced to read the studies have absolutely no clinical overlap in what they're being asked to interpret. So considering all of that argument, I would love to hear everybody's opinion and thoughts on making this more of a regular part of our practice and even installing it into our residency program so that the future plastic surgeons are better equipped to take care of their patients. Thank you all.
Thank you for that amazing summary, Dr. Glener. I think that the points that your studies highlighted are so important because, as we all know, that with the FDA approving ultrasounds as an adjunct or as a preferred way of monitoring silicone breast implant surveillance, it's really is an easy modality, a very non-invasive modality that patients can be utilizing, that we should be encouraging our patients to utilize for ensuring that their implants are intact and to really get ahead of any problems. I think that it was really interesting. Some of the statistics that you also mentioned in the introduction part of the study is just, that 8% of asymptomatic patients have ruptured implants. That's what the incidence is. So I think that, like you've said, and that, our society is moving towards with all the implementations of the various courses at all the meetings, is the importance of each and every single one of us having this feeling confident with utilizing ultrasound in our own practice and going about that. So I think it's great that you highlighted the importance of incorporating this into our daily practices, but also gaining that training up front. So I wanted to know where our panelists and our participants thought that this would be going in terms of really becoming integral as part of a plastic surgeon's training program, and when and where we should be implementing that, and whether any programs have already started with that.
Maryam, are you asking? Who are you asking?
I'm asking everyone. So Dr. Adams, why don't you tell us? I believe, if I'm not incorrect, I've heard that you've spoken to this being part of the residency training at UT Southwestern. Is that right?
Yeah, absolutely. And if you think about it, we are really the last surgical specialty to embrace ultrasound. Every other surgical specialty, whether it's surgical oncology, trauma surgeons, general surgeons, they all are using ultrasound every day, and the surgeons are the ones that are delivering the technology. So it makes total sense for this to be taken over by plastic surgeons and plastic surgeons to embrace this. And as Adam presented, I think that there's been a groundswell of plastic surgeons that are interested in the technology, but the great thing is that it can be done very easily, very accurately. And what I would say to end with is just your patients will love it. I mean, MRI for surveillance, as we all know, for many years is a failed recommendation. In fact, at 2019, in the advisory committee meeting, the panel actually recommended to the FDA that they drop ultrasound as a recommendation. That they ended up not doing that. They just added ultrasound as an accepted surveillance tool. But it's far more accurate, far easier. Patients 100% tolerate it and like it much better. It's done in the office, and it's just really a great thing to offer your patients. So yeah, it should definitely be something that's incorporated into training programs. I think plastic surgeons that are in practice, the societies. I mean, Pat McGuire and I and Pat Pazmino all have kind of been delivering educational ultrasound courses now for many years. And so I think it's one of the there's always technologies and things that come up in our specialties that are kind of truly landmark and transformational. I think this is one of the probably top two in the past 10 years that I've seen. So I would highly recommend people get an ultrasound and start doing this, because you'll find not only is it a useful tool for you for a lot of reasons, it's something that's a big benefit to your patients.
I think that's really great. Speaking of, I think you were pointing to some of the perceived barriers to entry with bringing ultrasound on board into your office that I think that if you and our other panelists could speak upon would be really helpful to our to everyone on this call is how would you recommend incorporating this into a day-to-day office operations? For example, speaking to some of the, there's some upfront costs, obviously, but in addition to that, in terms of resources, what you recommend in terms of integrating it, just in terms of extended appointment time, do you delegate any of this service? It would be really great to hear on some of that, because I think those are some of the challenges that some people may feel to their incorporating this into their practice as opposed to outsourcing it with external imaging.
Yeah, and I'm sure Pat will have some good comments on this as well. But there's a lot of technologies out there. The costs are not, when you compare it to some of these lasers that you end up using for a year and then they're in your storage room for the rest of their career, they're not that expensive. So I would caution people, and what you can do is if people have questions, you can certainly talk to some of the people that have some experience with it, because you'll get a lot of details that may be helpful for you. But you can get ultrasounds for as low as $2,500 or $3,000, up to some of the more expensive units, maybe 20,000, 22,000. But you're going to keep those for many years. And what you'll find is the more expensive units, the resolution's better. It's a lot easier for a neophyte to not get confused. What happens in some of the lower resolution ultrasounds is you get this reflective artifact, and it can be difficult for a neophyte to get comfortable with it. That being said, I think that's the number one kind of hurdle for plastic surgeons to get over. And just remember, like the way to do it is to get experience with it. So you certainly can go to the symposium courses that are offered by the society, but just start doing ultrasounding your patients. You always have the opportunity, if you're not sure at the beginning, you can send that patient to a radiologist for a second opinion ultrasound and compare that to what you've gotten. You can send images to trusted colleagues. There's a lot of options for that. But for a given practice, one of the things that was important to me is that I wanted to be able to upload my images to my EMR, because I just felt like it would become a little bit cumbersome if I didn't have that capability. So I chose the ultrasound that I use now as one of the things I wanted to have. But everybody's a little bit different. Pat, I'm sure you all have additional insights on this.
Absolutely. And thank you. I absolutely agree with Dr. Adams that this really is revolutionary technology, and it's just very, very accessible. And I mean, I really think that one of the most important tools that we have as a plastic surgeon is our ability to communicate. And that's what this does. It allows us to communicate with patients. And just like Dr. Adams said, if you look at the video that he included in his paper, it's a very interactive exam. That when you're doing this, the patient is watching you do this. And by the time you get to the second side, I mean, the patient can even tell what's normal and what's not. So it gives the patient just a lot of confidence, and it really helps establish a good relationship with your patients. It also, like Dr. Adams mentioned, it really helps you stand apart. Because if a patient is going to 3 or 4 different consults and you're the one that brings out the ultrasound, you are going to stand apart. You are going to be the plastic surgeon that cares, a plastic surgeon that has more ability, and that inspires confidence. And I think it was Dr. Bengtson that said that the person that finds the implant rupture is the one that gets the case. So I think that's really, that's important to note also. One other thing I would say is that I think, something to help allay people's concerns is if you look at the paper, if you look at the discussion, if you look at all the comments, the only thing that we're talking about is the implant. It's just about implant, implant, implant. And as plastic surgeons, I really feel that that's what we should be focused on. So, we don't use this technology to go ahead and look at the breast tissue. I think that's a very important thing to tell the patients. In fact, the Aesthetic Society with Dr. Glixman, they put together a consent that we have the patient sign, indicating that we will only look at the implant, that this does not look at tissue. I tell them this ultrasound is not able to look at tissue, so that the patients understand they should not miss a screening mammogram, or that this is not a replacement of a real breast ultrasound. And I think we should make that consent available too, because we need to tell the patients and everyone else that we are plastic surgeons. We're not radiologists. We're not interested in the liability and the concerns of assessing soft tissue. We just really want to know about the implant and possibly the capsule.
Yeah, and you can always give the patient the option to, if their surgery is going to be based on what you say, then if they want to get an MRI, fine. But Caroline Glixman and Sarah Ferenz and I published a paper, 480 patients with operative confirmed readings. And after 30 patients and 60 implants, we started 100% sensitivity and like 88% specificity, and we got to like 95% after 30 patients. And as long as you take this with you to the operating room and confirm your readings right away, it's a very quick tool to learn. As far as time in the office, I think it reduces the time on a lot of consults. If you have that textured implant patient who's worried about it and my breast hurts, is my implant okay? I used to see these people say, well, I think it's okay. Everything looks fine to me. But Bill was the one who got me really thinking about this probably 10 years ago. And I've been doing it routinely for the past 6 years. Yesterday, I saw 3 new patients. 2 of them had implants that were over 10 years old. 2 of the 3 had ruptured implants and scheduled surgery. So these devices pay for themselves very quickly. And as Pat Pazmino said, it's the best communication tool you can have. You can really put patients at ease. My breast hurts. Is it my implant? And they're looking at it with you. They see that the implant is okay. They see that it's ruptured. I've had patients, you do one side and you go to the other side. Oh, that looks different. Is that one ruptured? So it's not that difficult. We're not looking for aortic aneurysms. We're looking for the integrity of an implant shell. And it's at the aesthetic meeting at Austin. Please come Friday afternoon. Pat and I, Mark Salzman and Caroline Glixman have a course. There's a lot of interest in this. I can't tell you how many people have contacted me that they're going to be at this course. It's really very good. It's hands-on. And I have surgeons come spend a day with me in the office. If you can get somebody who's doing a lot and just see it and see how you flow in the office, it's the best piece of equipment that I've added to my practice in 33 years.
That's really great to hear. And it sounds like all of you are using it routinely, both in your consultations, but also it sounds like before almost every implant revision case that you're doing. I want to know, is anyone utilizing their ultrasound, beyond just the application of is the breast implant intact or not, as part of their breast revision surgical planning, looking at maybe trying to assess, sometimes we have patients that are coming in from abroad with implants that are forever old, that have no idea about the details. Their tissues have completely changed. They don't know the size of their implant or what kind of implant they have. Do you find that you're utilizing it in other ways? For example, trying to determine, is this a textured implant? What kind of implant could it be, aside from, saline versus silicone? What dimensions could this be? How much is the tissue thickness? Like, how am I, if the patient wants to be smaller, how much am I downsizing this patient? Is anyone kind of integrating that into their surgical planning as well?
Yeah, 100%. Just as you know, Maryam, the technology can tell you as much as you're able to interpret from it, right? So in revision cases, it's incredibly useful because, for example, if somebody comes in to see you with a firm breast, like, is it capsular contracture or do they have a seroma? In 2 seconds, you can diagnose that. you know, all the implants have almost like their little DNA, how they look on ultrasound. As you do more and more, yeah, you can see different, you know, different type implants. But you can look at anatomy. A lot of times what I do and look at on these revision cases, for example, that you're going to do, say, an implant exchange. Obviously, there's other ways to tell the pocket plane, examining the patient, but an ultrasound, it's like perfect. You can see exactly where the muscle is, but what you can see more with ultrasound is you can see how much muscle coverage they have. You can see if their muscles overdivided up the sternum, which is, you know, very common, and may impact your decision. For example, if I see somebody that has thin soft tissues, needs implant exchange, they're under the muscle, but it's like the top 10% of the muscle because they've been overdivided. You know, I may not do a mastopexy in that patient primarily, and because I can show them, hey, this is your anatomy. We're going to do this in a staged fashion. So there's an incredible wealth of really great information that you get clinically beyond just whether the implant's ruptured or not.
And that's really, really true. And then, you know, I know that we've talked about some of the different signs and how presentations can be, and the best way to really learn ultrasound is to hands-on and with experience. But are we moving towards, as a society or anyone in particular, towards building a library of images that or videos that patients can, that surgeons can use as additional resources, build up their knowledge base of, you know, different signs to look at. You know, we talked about, you know, the shell relative to, you know, extravasated silicone gel and there's intracapsular ruptures, but we have extracapsular ruptures. We have cases where you have the step-off sign and, you know, just shells disintegrated, the most obvious of them all. But I think that would be really helpful for beginners, especially, to have access to, you know, it's really commendable that everyone is so willing to be accessible for surgeons to reach out to them as colleagues for their insight. But do we know if we're moving towards something like that?
I don't know that specifically is under development, but it's certainly a good idea. You know, it's something maybe that you know, both maybe the journal and society can look at some option to kind of build something out. I do think that the ultrasound courses that are offered both at the annual meeting and then at the usually at the breast and body symposium are recorded, and those are accessible on the on-demand platform. So that may be another resource people can tap into that are looking for additional educational material.
That would be really great. I think it would be a great adjunct. Now, Drs. Adam and Glener, you mentioned in your study that, you know, in the case of implant rupture without necessarily impacted capsule in any other way, you're opting to leave the capsule intact unless, you know, there's another pathology involved. Is that also how Drs. McGuire and Dr. Pazmino, is that also how you treat implant ruptures? Are you leaving the capsule alone? Are you trying to take that out? What's your take on this?
Depends on the patient. It depends on the circumstance. You know, if a patient has, my indications for capsulectomy or capsular contracture, extracapsular rupture. I do like to remove capsules when I'm removing textured implants, if I could do it safely. I respect a patient's request to have their capsule removed with an informed discussion. I see a lot of the breast implant illness patients, and we now have a lot of data showing that it's not necessary for symptom improvement in these patients. But I think it's a discussion you have to have with the patient because it does increase the risk. With a ruptured implant, sometimes it's cleaner to remove the capsule. But I actually did one today where the capsule was so thin, I think it would have caused more of a mess if I had tried to dig that thin capsule out than opening it up, taking out the ruptured implant. And the capsule was so thin, it would have caused more trouble if I tried to remove it than to leave it alone.
Yeah, I tell you, one of the things I've learned over my career, kind of this epiphany I had probably 10 to 15 years ago, was that capsulectomy in itself is not benign at all. And that not, beyond the kind of typical things, the bleeding things and things like that. It's it's the internal structure that's controlling your position, your implant. And what happens is there's a trade-off taking the capsule out, and sometimes that trade-off is worse than what they had at the beginning. So I not dissimilar to what Pat said, it's clinically depends on the situation. Sometimes you need to take it out. If you get in and it's calcified or things like that, then yeah, you definitely take it out. But especially now with like Gen 6 implants, the more cohesive implants, the gel and the implant comes out very easily. You can simply clean out any little oils and small amount of gel that may be in the pocket. And my experience with that approach and that type of patient has been superior than just doing the capsulectomy on everybody. So it's kind of a little bit of a clinically based decision process for me on this.
Especially if you're replacing implants. If you lose the control of that pocket, it's really difficult to fix. So, yeah, if you don't have to remove it, don't.
Okay. I think that's been really excellent so far. Deniz, what do we have going on in our chat box? I do see that there's activity there. So do you want to
There's a lot of
fill us
activity in the chat box. So I actually have one question for the panelists. The authors said, and then we'll get to the chat box. Luckily, Dr. Glicksman has been in the chat box and she's been answering questions, and it's actually very helpful. For the panelists, the authors mentioned that they screen their patients for rupture at 5 years and then every 5 years after, and that they also charge, and the patients are not bothered by that. How do you approach this in your practice?
I do not charge my patients for ultrasounds or follow-up. It keeps them in the office. I think Brad Bankston did a paper where he showed the patients schedule surgery, they make appointments with your estheticians, they get injections afterwards. I don't think it's wrong to charge patients for it. I think some people have models like if they schedule surgery, they'll throw in certain numbers of cases. I have not charged my patient. It takes me less than 5 minutes to do. The patients love it. They send their friends to you. When you do an AUG consult, especially if the patient's there and her family member or somebody else is there, and you tell them, yeah, I'll see you every few years in the beginning. I'll do an ultrasound at 5 years. They'll schedule surgery with you. My coordinator says the patients will say, wow, you're willing to see me, not charge me anything for this. They'll schedule surgery. So I think it increases your conversion rates. And I think everybody has a different approach to this. We have chosen not to charge for it, and I think it's paid for itself.
And what's your screening schedule? 5 years and then 5 years?
I still do 3 years and then 5 years, because I have them. I see them a year after the nog, then I say come back 2 years later. As long as it's there, I'll do an ultrasound because it takes a couple minutes, and they love it.
Yeah, routine screening we usually do every 5 years. And I think based on the data of the study, I would say that even supports it more, because at 20 years, only 10% of the implants have any kind of issue. So every 5 years works. We do charge patients. My perspective on it is, look, when people come back for Botox, do you charge them for your inject not the product, but the injection? And I think it's another skill set that you've learned. You're delivering your time and your expertise. We found, again, the patients are ecstatic to come to your office and get an ultrasound, and not have to go to a center and have, that's a gong show for them. And so so we haven't really gotten any pushback at all from the patients on it. And it's not like we're charging them an arm and a leg. We charge $200 for a surveillance ultrasound. If somebody comes into my office with like a presumed seroma or some, and it's part of the diagnostic consult, then we don't charge. That's something we won't charge for. But for surveillance, we do. But yeah, Pat McGuire and Caroline Glicksman and I have been doing the ultrasound courses for a long time. We all differ on that a little bit, and I think whatever works for you is fine.
Dr. Pazmino?
No, I'm very similar to Dr. McGuire. I see the patient a year afterwards. And so I'll scan them a year and then 3 years later. And so really when it comes to this, I mean, it's, Dr. Adams is absolutely right. It's just about your perspective. I mean, when we talk to patients, we don't talk price, we don't talk cost, we talk value. And so when we see these patients at the beginning and for a primary aug consult, we tell them that you're going to get your primary breast augmentation, but on top of that, we're going to enroll you into a lifetime surveillance program. And we're going to follow you closely. We're here. We're not going anywhere. And we're here to establish a long-term relationship. And then that really, it comforts the patients. And I think that it also helps you stand apart because not everybody else does that. What I would say is that, of course, I charge my patients every time they come in for Botox because I pay for the Botox and there's a disposable. Here, this is the great thing about ultrasound. There's no disposable. There's no ionizing energy. So you can scan people every single day if you want. This past year when my wife was pregnant, I would scan her every single week because it's free and it's fun and there's no ionizing radiation. So, I really don't see this as a product. I see this more as an extension of the physical exam.
And in terms of documenting your findings, are you creating some sort of actual image report, or are you just putting your document in your regular note, like this is what my ultrasound showed? How do you guys document for that?
Yeah, so we have a note that details what I basically have a templated note that details, if it's a normal ultrasound, I usually comment on the status of the implant, whether it's under the muscle, over the muscle, and then any kind of additional notes I feel like I want to write. But and then what I do is in the paper we Adam included a video that shows kind of the whole process of delivering the ultrasound to a standard surveillance patient. So again, I do it in a very templated, systematic fashion. So we start in the right breast. I take a photograph, and my staff kind of helps because there's hotkeys on the ultrasound that label it for you. So we take a still picture at 6 o'clock. I look along the lateral part of the breast, the medial part of the breast, and then we take a video from 6 o'clock to 12 o'clock. And those get labeled with these hot buttons as we're doing it. Then we go to the other side and do the same exam. And so those 4 images, two still images and 2 videos go into the patient chart. And I think that's useful because you will have sometimes that, let's say you go, like in this study, as Adam Glener reported, when we saw an implant that we felt like was ruptured, it was 100% predictability. So like when we think there's a ruptured implant, we never were wrong about that. And that's because that basically pristine architecture is lost in people that have a problem. So I think it's relatively easy to get used to looking at that. But as you start out, you may have and we had a few false positives where we basically thought it was intact, but it wasn't. And so, you want to be able to go back to those images and go, okay, well, how did I miss this? And what I usually find is like, what was I thinking? How did I not see this? It doesn't have the normal architecture. And so that's why I capture the images. And again, we use the consent that my personal attorney, Dr. Caroline Glicksman, made for me. It just basically says that this is ultrasound looking at the breast implant. We're not looking at the breast tissue. We're not diagnosing breast pathology. We're not diagnosing breast cancers. And it's just a simple thing. And again, never had a problem with it, but we do get that consent on every ultrasound patient.
Is there anything different? Do any of you see insurance-based patients at this point? And do you document anything differently or bill anything differently if you do this for those patients?
I've not done any insurance.
I don't know, but I've heard that I've heard people say that they could submit some sort of code, for doing an ultrasound exam. I just don't know exactly if that's worked or if that's more trouble than it's worth.
Okay. One other question, the asymptomatic patient with a rupture on ultrasound. There's a little bit of a learning curve. We mentioned false positive, false negatives. Are these patients that you were like, it's ruptured, we should go to the OR? I know Dr. Adams in his publication, they said they recommend removal of ruptured implants, pretty much across the board, if I'm summarizing that correctly. So the asymptomatic patient with a rupture on ultrasound, how do you manage that? And is there any risk of going to the OR and being like, oops?
Adam, why don't you answer that? I think your perspective is really good for people here too, because, you didn't come in with a huge amount of ultrasound experience, but so why don't you address that?
Yeah, I think it's a great question, and obviously I'm newer to this than a lot of the people on this panel, and I've talked with other people who have graduated from other fellowships who are contemplating using ultrasound in their practice, and that exact scenario arises. And I think, as somebody who's not as comfortable with it, you have two options. You can always send that patient to another radiologist for a confirmatory study, or you have a very honest discussion with the patient and say that there's a high likelihood that this is ruptured. And, unless you want to confirm my opinion, I think we should go to the operating room, because I agree with Dr. Adams. If you have a ruptured implant, I think all of us know that the likelihood bad things are going to happen is much higher than if that implant is intact. And I don't feel the need to wait for contracture to set in to then make my corrective maneuver that much more complicated.
Dr. McGuire, the asymptomatic patient with a rupture on ultrasound?
Yeah, the ultrasound doesn't lie. So I believe the ultrasound, and the patients will usually see that with you when they're looking at it. They see that one implant may be different than the other, or I can, if both are ruptured, then I can, pull up on my ultrasound an intact implant and show what that looks like. And the patients often, I would tell them it's not an emergency. We don't have to do this tomorrow. Figure out a time that's convenient for you. But now it's time to start making plans on what you're going to do. In the beginning, when I first started doing this, I would you tell the patient, if you're not going to have surgery unless this is absolutely ruptured, then we can send you for an MRI. My experience is the manufacturers will honor, let's say you read something as a rupture and it wasn't. If you send them because we've asked about this, if you send them the ultrasound what made you think there was a rupture, they will honor the warranty.
And what about additional costs for that patient for a false positive, early on, if you've taken a patient back and it wasn't ruptured, aside from what the warranties covered, has anyone had to deal with that scenario? What kind of discussion have you had before or afterwards with the patient?
So,
that's more from the radiologist reading. I've never had one where I read wrong. I've had more where a radiologist read an MRI as a rupture, and then in there and it wasn't ruptured.
In the study, the positive predictability was 100%. So, there wasn't any case where we said this is ruptured and it was not ruptured, which I think is probably the best scenario. We are really lucky that, ultrasound is so much better than MRI, and I even would question the accuracy of a lot of the MRI studies, because there were so many false positives and negatives with MRI that if patients are actually doing them, we would have had, hell to pay with that exact scenario, because so it's maybe a bit fortuitous that it was so labor intensive for the patients that they didn't do it. Yeah, I think you have a lot of resources with this technology. Not only can you, refer them to a radiologist, you can send an image to a colleague to get their opinion. You can bring, again, patients view a rupture as like this explosion that's an emergency. It's definitely not. Just like Pat McGuire said, you can always bring them back the next month, and re-ultrasound them again. If you're like, I think this is ruptured, as you're trying to figure out a time, but let's just repeat the ultrasound, and you can do that. So there's a lot of options. But the good thing is that when you see that kind of pristine architecture that Adam showed in the presentation, that's classic for an intact implant. And what happens is you lose that, not completely, but there's something that just doesn't look right. When you look at the ultrasound, and the more you do these, the more quickly you do it. So it's like and another thing that I didn't make this point earlier, but I think it's important. You're not looking for the needle in the haystack with this.
Mm.
There's changes that happen when there's a tear in the shell. Even though we have more cohesive implants, the oils and a little bit of gel gets on the outside of the shell. And that's what you're seeing. Like the image she showed is just a small amount of gel that's on the outside of the shell, but you get that even with the more cohesive implants now. And so that's what you just lose that normal architecture. So it's not that you have to find a little tiny tear in the shell and implant. Sometimes you may see a disruption of the shell and implant, but you don't have to. You see these other findings, much more often when you're diagnosing a ruptured implant.
You know, one other
Mhm.
thing is we tell our patients that if your breast hurts, if your breast gets swollen, call us first. Because they call the gynecologist or the primary care, they may send a patient with a seroma for a mammogram. And a lot of the insurance companies won't pay for an ultrasound or won't pay for an MRI until the patient's had a mammogram. These poor women are being tortured. When I say, call us, and our nurses are trained to, maybe not for subtleties, but they could see a seroma, they can tell most ruptures. And we tell patient, we'd rather you call us and let us see you and do an ultrasound than go to the gynecologist and then end up waiting 2 weeks to get a mammogram, and then your insurance won't cover an ultrasound. So, and that patients, that's very comforting to them. If your breast hurts, we'll see you. We want to rule your implant in or out from that process. And that patients really appreciate that. It shows, like Pat said, that you care about them and you want to take care of them. And it gets them back in the office.
Mhm.
I think that's really key, is just being there and providing that comprehensive care for patients, because really it is, part of the care, that surgical care that we are able to provide for patients. And I think patients really do ultimately appreciate it when we're able to be there for them. Now, just to wrap it up, I just want to know, we've spoken about surgeons incorporating this more and more into their practice. Where do we see the actual technology going, with everything being AI related nowadays? I see Dr. Pazmino nodding along. Where do we see this going? Is there new technology that's coming down the horizon? And are we going to get even more information out of this modality? Sorry, we can't hear you, Dr. Pazmino.
Yeah. You're still muted.
No.
It's not muted. Something must be off.
Can you hear me now?
Yeah.
Yes.
I just switched microphones, but I was going to say that's exactly right. That's where this is all going. Artificial intelligence, and right now, artificial intelligence is already helping. It's already being a second opinion to radiology opinions, and this is really spreading very rapidly in radiology. And so we do have artificial intelligence with ultrasound in the soft tissue setting. And so, for example, when we do BBLs, one of the companies has a mode that can go ahead and turn the soft tissue and make it look like a cartoon, so you can see the tissue planes. So that's exactly where this is heading. I would predict that in the future we're going to have ultrasounds that are going to be like those old EKG machines, where the EKG machine would come out and it would come out with a temporary reading, and we would have to confirm it. I think the important thing to understand about the ultrasound that we're talking about for plastic surgery is that these are very simple structures, and we're looking at the same thing over and over and over again. The anatomy is very repetitive and very, very straightforward. And so when we're doing this, we're looking for that train track for the implant shell. And if that's disrupted, then that's what alerts us to a problem. And that's exactly what artificial intelligence is great at. It's you're really tackling a discrete problem. So that's coming very soon.
That's exciting to know. That's exciting to see. Well, we're getting close to 50 minutes on the mark, and I would like to, I know that we have so many busy surgeons and our panelists on the line, and we've been so fortunate to have such a thorough discussion tonight. I want to thank everyone for their participation today and their expert insights. And I'm sure that everyone here on this call is motivated and further encouraged to incorporate ultrasound into their bread and butter portion of their office, their breast surgery work, because it's not only what we can deliver to the patients, but it also is beneficial to the practice itself. With that, I'd like to thank everyone. I hope everyone has a good night, and please don't forget to stay tuned and join us for our next ASJ Journal Club, which will be announced via social media and all our newsletters. So thank you again. Thank you, Deniz, Sarhaddi. Thank you, Dr. Adams. Thank you, Dr. Glener. Thank you, Dr. McGuire, and Dr. Pazmino, and everyone else who joined us this afternoon, tonight, depending on your time zone, for this really great discussion. It's been an honor to be able to start off the year with such a great bang. Thank you.